Hello, and welcome to Let's Talk SADS Live Canada. I'm your host, Dr. Shu Sanitani, and I'm coming to you from Vancouver. And it is a wonderful morning here, a little bit of much needed rain. And welcome wherever you are picking up our live webcast. I understand a lot of you watch this in your homes at the end of the workday. Thank you for joining us. I am really privileged to be part of this conversation. We've been going almost a year and a half now, trying to educate our community in a collaborative way. I've probably done most of the learning because I have these wonderful guests who teach me so much about sudden arrhythmia death syndromes, SADS conditions. And we've had some really tough questions from our audience as well, which keep us engaged and doing this very intentionally to advance the field and to learn together. So we've just come back from a very big meeting, the Heart Rhythm Society meeting, which is known often as HRS. It's an international conference that this year happened to be in Boston, and there was a lot of new information on the sudden arrhythmia death syndromes, the SADS conditions, some of which we're probably going to learn about over the next several months in our sessions. So excited about that and all the science that's going on. So as you know, I like to do a couple of housekeeping things before we get going here. I want to tell you a little bit about the Hearts in Rhythm organization. So the Hearts in Rhythm organization is a nationwide Canadian organization that works closely with SADS, organization of healthcare providers, physicians, researchers, and patient advocates, again, aimed at advancing the field of hearts in inherited arrhythmia condition. And they are having their annual meeting in Toronto on June 7th and 8th, but there's a public forum on the Saturday, June 8th in Toronto. So you can scan the QR code to get more details. And SADS has been a partner in this now for a few years. And it always brings a lot of energy and attention to the importance of these conditions. So that's coming up in a couple of weeks. And as part of this, there's also a session, an industry panel live stream, and some of the companies that are developing these new therapies are going to be present there and really educating us a bit about what's coming and what they're working on. So a real behind the scenes look before some of this information is really out in the public domain. So it's a real treat. And that is going to be live streamed. So you don't have to attend in person, but again, scan this QR code. And you see there on the slide, we're talking gene therapies and new molecules. And so over the next few programs, we're going to be referring back to this. Certainly the treatment of SADS conditions is evolving rapidly, and it's an exciting time. I used to think that what we were doing for many of these conditions would be the same throughout my career. And now when I meet new families and they say, are we going to be doing this forever? The answer is certainly different from what it was. So if you can join the industry panel live stream, you will be in for a real treat about things that are not known by everybody, but definitely may impact your treatments. Continuing on from last year, where we provided some trivia, Canadian trivia, this year we're trying to give you some interesting facts about some of these inherited arrhythmia or SADS conditions. And so these are just some of the things we've brought to your attention. Arrhythmogenic cardiomyopathy, changing its name. And the first ECG of a child with long QT was published 100 years after the initial description. So the technology had to catch up. And so today, again, along the long QT, I just want to talk briefly about the deafness that's associated with a very severe form of long QT, or Jervell Lang Nielsen, some of you know it as, where you actually have two genetic hits. So most long QT, one just inherits from one parent or the other. But if you inherit two copies, or you have a new copy and inherit one copy, then you may also end up with deafness. And the deafness is because your potassium channels are very important in your inner ear in terms of the fluid shifts that need to happen for your ear to be able to perceive sound. So I only scratched the surface of this, that I realized that hearing is actually as complicated as heartbeat, and lots of ion channels involved. But the potassium channel, which is the cause of long QT types 1 and 2, can be involved in this deafness. So that's our Did You Know? I'm delighted to introduce our guest today. So Dr. Beth Stephenson is a professor of pediatrics at the University of Toronto and the section head of cardiac electrophysiology. She is also a dear friend. Our training overlapped briefly in our trips through Toronto. She hails originally from Massachusetts, and I'm going to bring her into the studio and let her tell us a bit more about her path into SADS conditions. And we're going to be talking to Beth today about cardiac rhythm devices. So welcome, Beth. I am so glad to have you here. I will confess now that I'm going to struggle to call you Dr. Stephenson because we have known each other so long, but certainly you are known internationally as Dr. Stevens, as one of the leading electrophysiologists in Canada, including on cardiac rhythm devices. So welcome.
Thank you. Beth is just fine. No need for formality. It's really a pleasure to be here with you and the audience. It's great to see families really trying to learn and advocate for themselves. So this is a great forum. I'm thrilled to be a part of it.
Now, tell us a little bit about your background, because although you are you may in fact be a Canadian at this point, but you tell us a bit about your journey from college and medical school and how you ended up in Canada.
Yeah, absolutely. So I went to college, as we call it in the States, in Massachusetts, and then went on to medical school at Columbia University in New York City. And from there, decided I knew I wanted to do pediatrics. So I was lucky enough to match at Boston Children's Hospital. So I did my pediatrics training there, and I stayed on for cardiology and electrophysiology. So I did many years in the Boston program, which was a wonderful place to train. And then I came to Sick Kids, my first job out of fellowship way back in 2003, and not knowing a lot about Canada or Sick Kids, but knowing it by reputation, and excited to work there. And I've stayed ever since. So I've been at Sick Kids for coming up on 21 years. And it's been a pleasure. I am now a dual citizen, Canadian citizen as well, which I'm quite proud of, and really thrilled to be part of the Canadian EP community, which is small but excellent.
Well, thank you. And I will add that we could have you on this show with a completely different hat. It has been almost 10 years, I note, that you have been the chair of the Research Ethics Board at Sick Kids, which is a huge responsibility, and providing oversight to all these research projects that to ensure that things are running in the best interest of the patients and protecting also the researchers. So a huge responsibility.
Yeah, it uses a very different part of my brain from my arrhythmia work, which I really like, and I love the fact that I get to see all of the kind of leading edge science that's happening all across pediatric medicine, not just inside cardiology, but a lot of the things that are happening in metabolic illness or pediatric surgery or oncology, and that's really an honor to get to see all of these things as they start. And you mentioned in your introduction some of the very exciting new technology in terms of gene therapy and things like that that may be applicable to some of our patients. And I'm watching that same technology start to get used and tested in other pediatric diseases, and it's a pretty exciting time.
Yeah, and it's so important to have some some guide rails around those things. Today we're going to talk about devices, cardiac rhythm devices, and this is something that comes up a lot for our SADS patients and their care providers. And let's just go right back to the basics here. Tell us briefly, the terms that people hear a lot are, an implantable defibrillator or a defibrillator, ICD, versus a pacemaker. Maybe just start with those to orient our audience. And I know that you've done some very cool graphics so that now you look like you're in a room with a device there.
Yeah, so hopefully this does show up okay. I thought we'd try to use this more immersive form so that I can point at things and you can see what it is that I'm talking about. So what we have on my shoulder here is a schematic of a pacemaker, and for both a pacemaker and an implantable defibrillator, the core parts are very, very similar. So each one starts with a generator. So that's this portion here, which has the battery where the energy comes from, the circuitry, which is the brains of the device, often an activity sensor, which can help change the rates. And all of that is attached to a lead, which is a thin, flexible wire coated in a very soft polyurethane, kind of a rubbery plastic. And that's what actually attaches to the inside of the heart. And the design of an implantable defibrillator is very, very similar. The battery is bigger. The brains are very similar. And then the lead itself has not just an electrically active tip, which can transmit electricity of tiny little pulses of electricity that can trigger a heartbeat, but it also has another section on it here, which can deliver a much bigger amount of energy, which can reset a dangerous heart rhythm. And we call that the coil. So every implantable device has these basic components, all of the ones that can control your heart rhythm, and they can be put in a variety of different places. The primary purpose of a pacemaker is to treat slow heart rhythms. So we use them when somebody's heart rhythm is unstable in a slow pace, which can be the case for some of the SADS conditions where they don't tolerate a slow heart rhythm, or it can be for somebody for whom the sort of electrical connection is not great, and we need to help that electricity travel through the heart in a normal fashion. The defibrillators are treated primarily to manage abnormal fast heart rhythms. So when people have dangerous fast heart rhythms, such as ventricular tachycardia or ventricular fibrillation, where the bottom chambers of the heart are pumping so fast that they're not able to really do a good job of pumping blood out, the defibrillator can put in an electrical shock to go ahead and reset that rhythm. And it's a lot like you see on TV when the emergency room shows put the big stickers on the outside of a person and they yell clear and there's an electrical shock. That's the same technology that we use, only in an ICD, an implantable defibrillator, you have a super smart computer that is with you all of the time, and the electricity travels from the inside of your heart through into the pacemaker. And because of that, it's a much lower dose of electricity and not quite as dramatic, but it is uncomfortable if you need that. I can show you just quickly, we'd like to see just what some of the typical things can look like for children, because in kids we can put the devices either into a transvenous location, which you see here, where it floats up through the shoulder. Sorry, there's a chair back in the way. See if I can make that go away. There we go. Or it goes down into the base of the heart, but it floats up through the brains, or through the veins of the heart. And then the other sort of common mechanism for implanting in young children is what's called an epicardial pacemaker. And this is where the body of the pacemaker is actually usually down in the abdomen, just under the skin, and the pacemaker wires go to the outside of the heart. So those are the most common positions that we'll see for these.
So pretty amazing that people figured this out. I was trying, as I was preparing for this, I was trying to find out when the first defibrillator was implanted in Canada. I was not able to find that. So if someone in the audience knows that, please let me know. The first one in humans was in 1980, so not that long ago, really. Certainly in many of our lifetimes, and there were about about 1,000 implanted worldwide in the first 5 years, I learned. But so now, of course, they're in much more common use. So the main components: computer, battery, some way of being connected to the heart. And then, of course, if you have slow rhythms, you might be fine just with a pacemaker. But if you have these dangerous fast rhythms, then your doctors might recommend a defibrillator. And then we should point out that within the defibrillators nowadays, there is a pacemaker also, so it can handle that. So you don't need both. And then let's just briefly, before we dive into this even more, I don't know if you were going to tell us a bit about the loop recorder. I just want to mention that so that we get our ducks in a row.
Yes, absolutely. So loop recorders are a very small device. So you can see here, this is in the palm of a hand. Now that's an adult male hand, just to be clear. They try to minimize it. It's a fairly large hand, but it's about the size of a tie clip. For our adult audience, will recognize that, and it gets implanted just under the skin. Typically on the left side of the breastbone, and it can monitor the heart rhythm. And these are enormously helpful when we find that patients are having symptoms that it's not completely clear exactly what they're experiencing. Maybe they've had a faint, but we're hoping it's not a dangerous faint, or maybe they've had a limited abnormal heart rhythm, but we're worried there's more of that going on. And these devices can sit there and provide extended monitoring, like an ECG. This is just another example of where it goes. Usually a couple of leads on an ECG, and it can be there for 2 to 3 years of monitoring, which can be tremendously helpful in diagnosing whether a patient is having any kinds of dangerous heart rhythms. You can see here it's implanted just beside the sternum or the breastbone, over the heart.
And yeah, I'm still amazed at the graphics. You have a career in the future as a weather person if the cardiology doesn't work out. The loop recorders we use a lot, especially in young people, I find, where we don't necessarily have the ability for them to vocalize, to tell us what's going on, and also where we don't necessarily want to put in a larger, more permanent device. So I'll ask the question. I mean, these people are diagnosed. Someone sits down with them and says, "You have a inherited, or you have a condition that is potentially going to cause a life-threatening heart rhythm that we cannot predict when it's going to happen. We can give you medications that don't actually eliminate the problem, but they reduce risk. Why do we not just give everyone that has long QT a defibrillator?"
Yeah, it's a great question. It's certainly something that we talk about in our clinics. I know you do as well. Is what we call risk stratification. So how do we decide who needs what level of therapy? For long QT, particularly, we have a fair amount of data, which is wonderful. That does help us identify people who we think may be at higher risk of having abnormal heart rhythms. One of the biggest indicators is just how long is your QT interval. The longer it is, the more we tend to worry about you. And when we do need to use these devices, they are very effective. However, they are not without risk, and they are not without problems. So, as I mentioned when I was first describing the defibrillators, it hurts when they go off. When I've had patients describe to me what it feels like, I've heard people say they felt like someone punched them. I've heard somebody else describe they thought it felt like getting kicked by a horse. It makes all of your chest muscles contract, and it's very uncomfortable. So we certainly wouldn't want to expose anyone to that without knowing that we really were likely protecting their life. The other piece is that because they travel through the veins, the pacemakers and defibrillators, the most common kinds, they do carry with them a small but real risk of infection. And in the worst case scenarios, that infection can actually travel to the heart and damage the heart valves or worse. So we take that risk very seriously. It's very small, but when it happens, it's very, very serious. And then, even though they are very sophisticated devices with a ton of safety features, they're not perfect. And sometimes they will read a not dangerous heart rhythm as a dangerous heart rhythm. For example, a very fast normal heart rate, somebody's running a marathon, something like that. Sometimes the computer will misread that and think it's dangerous and deliver a shock. And we call that an inappropriate shock. When somebody gets a therapy that they didn't need for their heart rhythm, and that's painful and very frightening and fairly traumatic. And again, not common, but also not rare. Even with the best of our programming, and we've learned a tremendous amount, and the right medications to help slow your normal heart rate, all of those things, still in probably 10 to 15% of patients, they will experience that inappropriate shock. So we really don't want to expose anyone to any of those risks unless we feel that it's necessary for their safety. And so it's really a very fundamental balance of who do we need to protect without exposing people to risks that they don't actually need to keep them safe.
And we heard some, even this past week in Boston at the meeting, we heard cases that are, so difficult to sort through. If a family has lost, one family member, they don't want to lose another one, and when they ask us, they ask us in clinic, well, what's the maximum you can do for us to prevent this from ever happening again? The talk of a defibrillator or an ICD always comes up. I think, to your loop recorder, the size of the hand comment, I think that's a great point, that these devices really are designed for grown people, and yeah, adult males are probably the biggest consumers of all of this technology. And so what are some of the things, because I know you've done some innovative things, what are some of the things you've done to make these devices work in children and young people?
Yeah, it's something that I think all of us in pediatrics spend a lot of time talking about. I will say that more than what any of us have done, the companies are constantly working to downsize these devices, which is tremendously helpful. The loop recorder that you see here is about a fifth of the size of the previous generation. The previous generation wasn't far off a pack of like Wrigley's or Juicy Fruit gum as a size comparison, and this is down to a tie clip, so that's fantastic. The pacemakers themselves have gotten smaller, and more importantly, the batteries have gotten bigger within the same sort of footprint, the same outside diameter. So they last a lot longer, and the brains are a lot more sophisticated. But we do sometimes, even with all that, need to adapt some of the adult technologies into pediatric environments. And I know that, one of the newer technologies that we're all excited about is the leadless pacemakers, which are quite small. Let's see if I can find the picture for that. There's too many pictures here. There we go. So this is an example of a leadless pacemaker. You can see it's quite small, and it gets delivered into the base of the heart on the right hand side, and it doesn't have anything attached to it. The batteries, the brains, all of it is right here in this little device. And while the size of the equipment that you need to get these there is still quite large, and isn't a great option for the smaller kids. For our teenagers, this is looking like it may start to be an option. And then one of the other things is, and I know that you've done one of these at your center, and we've done one at ours, is sometimes taking a device like this and adapting it and attaching it to a lead on the outside of the heart for our premature babies with very slow heart rhythms. And these are very rare. They're still what's called off-label, so they're not approved to be used in this way, but it can be a pediatric adaptation that can be life-saving in the smallest, particularly the premature babies. And I think that pediatricians are always looking for kind of new ways, novel adaptations of the old technology. The other thing that I wanted to share on kind of the, what's new front, there are two kinds of ICDs that actually do not sit inside the heart. One is called a subcutaneous defibrillator that sits along the breastbone and shocks through the bulk of the body. And the other that's just been released is called an extravascular ICD. And let me see if this is the right picture. So the extravascular ICD, just like the subcutaneous ICD, the what we call the box, the brains and the battery sit outside the rib cage underneath the skin. The lead goes across the front of the body, and then it goes underneath the breastbone. And you can see the part where the electricity is released goes all along underneath the sternum or the breastbone. The subcutaneous ICD is very similar. It goes on top, under the skin, on top of the breastbone. And the nice thing about this newest one is that because it doesn't have to go through the bone, it's actually sitting underneath the breastbone, is it uses less energy. So it's likely to be a little bit less painful than the traditional sub-Q. But more importantly for our patients, the battery is smaller because the battery on the sub-Q ICD is very, very large right now, and too big for a lot of our patients. I'm hopeful. We haven't used this yet. It's literally just, in the headlines. But I'm hopeful that this smaller battery will mean that some of these non-transvenous solutions will be more available to our kids.
Yeah, that's very exciting, that smaller configuration. And I must say, and I know you share this view, we're actually very fortunate in pediatrics because pediatric device implants is a tiny part of these companies' industry. I think less than 1% or maybe 1% of device implants are pediatric. Yet we really have a good conversation with the device companies and the engineers and the people that are being thoughtful. And I think they recognize that young people are an important group to serve, and also that it's if you can make it work for a young person, then it's going to be even that much better in the active 50-year-old and 60-year-old. And so everything that they're doing to help us and our patients is really making a better design. So yeah, absolutely cool. Now let's fast forward a moment. So you have had this device implanted, you've had the conversations, and you're you're going along just fine. Um, I'll put in an important point that the device itself is not a treatment in general. So you still have to stay on the, your medications and other things that your team has introduced. So, for long QT, for example, you still are on a medication. There are still drugs you have to avoid. You get a letter in the mail and it said, there is an advisory on your device, and the letter looks very important. It might even come, by a courier or something. Take us through that, because I get these notices as well, and they're always a bit nerve wracking. What is this process?
Yeah, absolutely. It can really be a frightening process and even intimidating for the physicians to figure out what they need to do. So an advisory is when a company has noted or been made aware of a problem with the hardware or the software of the device. And the challenge is really deciding how big of a problem this is. And there was a period of time when they called these a recall, and it was like a recall on your car. You get a letter from your car company saying that they found out that every once in a while this doohickey in this part of the car might go funny, and you got to bring it in, and we're going to give you a new doohickey. That's We don't call it that anymore because it is there are gradations of response. Sometimes we will see an advisory that simply says, you know what, the software in the device that runs the brains, that runs the computer, is on very rare occasions not recognizing this particular situation, and we want to fix it. So come in and we'll upload some new software and you're good to go. No big deal. Other times it's really very serious. Like we had about 10 years ago, 10 to 15 years ago, there was a new style of ICD lead, which was smaller. And in PEDS, we were super excited about this because smaller is almost always better. But in this particular case, two different companies came out with newer, thinner leads, and we thought it was fantastic. But it turns out they were prone to new problems that made them actually break. They were not working. Some of them were causing inappropriate shocks, as we talked about before, and some of them weren't delivering shocks when needed. And that was a very serious advisory. And for at least some of them, it was bad enough that it meant we actually had to take that lead out and give you a new lead. Thank goodness that kind of advisory is very, very, very rare. And most of the time now, when we see any kind of advisory, the most common response is, we're going to need to watch you a little more often. For example, some of them will say the battery calculations aren't as good as we thought they were. So we're not going to be able to tell quite as clearly when the battery is going low. So we want to see you a little more often so we can keep an eye on that ourselves. Or we've noticed that this particular lead is prone to a certain problem, but there are warning signs. So we're going to see you a little more often. We're going to look to see if any of those warning signs are happening. And then the software-based ones, those are kind of our favorites because there's usually a fix. There's usually a patch that they can upload, and they can fix those things. So you come in and we give you an update, and then you're good to go. So the language can be alarming, and there are rare circumstances where they're very, very serious, but a lot of the times they are just extremely rare events that we don't want to miss. So we say, you know what, this is only happening to 1 in 10,000, 1 in 20,000, but we're not going to be one of those ones. So instead of seeing you every 6 months, we're going to see you every 3 months. So if this starts to happen, we catch it early.
And we're very fortunate in Canada because we're closely linked to the Canadian Heart Rhythm Society, who have a device committee that looks at all of these notices, all of these advisories, and guides us. What's the evidence? Does the company's recommendation make sense for this patient? What should you do? And it's really, you've summed it up beautifully. It's mostly not a high risk situation, and thankfully, very uncommon to have something that is in fact dangerous. It's almost always, let's monitor more. And and these things come up because you may test the device on 1,000 patients, and now suddenly it's in 50,000 patients. So these small rare things may appear. Now, tell me about your practice. So if you have a a young patient, a teenager who has a defibrillator for let's say a previous severe arrhythmia or a cardiac arrest, what kind of lifestyle recommendations are you making specific to the device? Not so much about their medication and things like that, but on the device side, what are you doing, letting them do, not letting them do, those kind of things?
Yeah, it's a great question. So the first thing that I'd say is that the majority of the restrictions are actually driven by whatever the disease condition is. And so I think that's really important to know, because if you know other people with different SADS conditions or defibrillators for other reasons, for example, it's very common after someone's had a heart attack that they're prone to abnormal rhythms. So it might be for that reason. So they may be living with very different recommendations than you are with your ICD. So important to recognize that that does drive a lot of the recommendations. For the device itself, there are some things that can interfere with the function of the device. One of the most common ones is large magnets. So we do recommend that people keep electronics, which often have substantial magnets in them, and other things that might have large magnets. For example, large speakers, roller coasters. There are things like that that have large magnets or large electromagnetic fields that it is important to keep some distance. For most electronics, that distance is actually not huge. We usually say about 6 inches away from the device itself. But for some very large magnets, for example, the giant speakers that you might be exposed to at a concert, that electromagnetic field can be fairly large. So don't sit in the front row. Give yourself a little bit of distance. There are a few other things that can create electromagnetic fields. If someone is a welder, particularly arc welding creates a very large, powerful electromagnetic field. So when we're counseling teens as they look at careers, we do want to make sure that they're not signing up for a career that's going to be a problem. But most of these things are modifications. There are very few things that I would say, you have an ICD, you can't do that. I might just say, you have an ICD, this is how we're going to do that. I try very hard to work on making sure that a patient's life is set up in the way they can do the things that they enjoy safely. And almost always that's manageable with modifications rather than prohibitions.
Yeah, absolutely. Let's drill down a little bit on the magnets, because we talk a lot about this in our clinic, because every once in a while we'll find a magnet is troublesome in a common device. So I remember maybe a couple of years ago now, the newest iPhone, the magnets controlling the cameras were more powerful. I might be mixing up my technology a little bit, but suddenly having the iPhone, again, within 6 inches, was causing some interference. Now, these are not major disruptions of your device. That we remove the magnet and everything usually goes back to normal, but it's something, you don't want the iPhone sitting in your breast pocket next to your where your device sits. So but most small magnets don't create enough of a problem. But every once in a while, I remember also there was something about clothing. Someone had made very nice decorations of their clothing with with magnetic material. So you have to be a little bit cautious on some of these sort of unsuspected ones. But in general, we say, just keep everything 6 inches away. Are you pretty permissive about sports, especially Canada? The Vancouver Canucks have just been eliminated, so hockey's over out here. But hockey is one that, people say, well, can my child play hockey with this ICD, or or football? How do you work around some of that?
Yeah, so I am a very big fan of shared decision making. So I spend a lot of time educating my families as to what the risks are of that sport, whether it's because of the disease condition, or because of the defibrillator, and then we decide together what we'd like to do. The things that, from a pure device perspective, that I'm most concerned about is anything that will cause trauma to the device. And really, with that, what we're worried about is any of the extra cardiac portions. So where the pacemaker is sitting outside of the chest, there's a portion of the lead before it dives into the vein that is often fairly superficial, either here or down in the belly for the epicardial devices. And for all of the sub-Q systems, there's more exposed lead. So I worry the most about trauma to the device. A lot of that can be managed with appropriate protection, right? Wearing the right padding, wearing chest protectors, making sure that the padding, because the traditional sports padding is built to protect sensitive or important physical structures. What you want to make sure is that it's also covering the areas of the device that may be more vulnerable, like a section of the lead that's going to be a little bit more exposed closer to the surface. So for my kids that we decide together they're going to continue in a sport, then we do talk about protective gear, because every time you have to change a defibrillator, upgrade a lead, anything like that, there is some risk involved. So we want to protect these systems and make them last as long as they possibly can. But it is not a one size fits all. There are people for whom the sports are fun but not important, and they say, I don't want to take any risks with my device. It's not worth it. Or people who are very concerned about the risk of an inappropriate shock, which may be more when you're particularly active. They say, no, it's not worth it. And there are other families for whom this is a big part of the kid's identity. This is something that really matters to them. And so we're going to understand those risks and do our best to mitigate them.
And our colleagues Rachel Lampert and Mike Ackerman, they've done a lot of work on the safety of participation with in people with defibrillators, and generally there's not really any increased risk of to the patients or to the devices. So we really want to include that in, as you say, in our shared decision-making conversations. I know there's a lot of fear, especially if they've had events during exercise or sport. So
Yeah, absolutely. That the new data coming out is making all of us, I think, feel a lot safer, a lot more permissive about participation.
now, tell me, we're just a couple of minutes here. Are there some things that you're excited about? Is there going to be a time where we don't need defibrillators? We're going to be so smart with our personalized treatments that, the defibrillator will be go the way of the dinosaur. What are some of your sort of things that you're excited about the future?
Yeah, so I'm excited about gene therapy. I'm starting to see it take off in some other areas of medicine, and I think that a lot of the SADS conditions are potentially quite good targets. The process of developing that safely is slow, and it should be slow in a lot of ways, because we always have to make sure that we're not doing harm. But it shouldn't be dragging your feet through the mud slow. So it's good to have some advocacy, always pushing those things forward as well. But I am excited to see where that goes, and I think also on the device front, because I do think we are a ways from saying we don't need these devices anymore, but the devices themselves are getting better. The biggest risk to a pacemaker is the leads. We now have a pacemaker that doesn't have leads. So that's great. Is it good for everybody? No. Is it perfect? No. Is it going to have advisories? Yes, it is. It is a learning and a growing process, but constantly it's evolving. We have people working on pacemaker systems that they can use to pace a fetus while it's still in the womb. They have pacemaker systems that we can use to pace premature babies, which we used to have to keep in the hospital for months while they grew big enough to get a pacemaker. So I'm excited, even just in the short term, to see these better, smaller, safer devices for all of the people who can't quite get away from a device. Well, let's get them a better device.
Yeah, no, great perspectives. And I think, we as a community are also learning. We were talking about how we used to program devices for CPVT, and we've learned so much over the last 10 years about that specifically. So we are getting better at doing it as well. So Dr. Stephenson, it has been an absolute delight having this conversation with you. I'm going to have to learn how to do that cool display of graphics, but more importantly, you're a wonderful source of information and perspective about this. And we are going to keep you in mind to have you come back with your chair of the REB hat sometime. Um, but thank you so much for joining us today.
Oh, well, thank you so much for having me. It's been a pleasure. It's a great conversation, and it's just wonderful to see families who are really reaching out to learn everything they can so that they can take great care of themselves. I love that.
Thank you. Great conversation. What a nice job she did of outlining. And I think some of our audience, they may even want to use this to educate their family members, when they're coming up for potentially a device replacement or a new device, just to explain some of the differences. It's remarkable how hard it is to find good information. And here, of course, here at the Canadian SADS Foundation, one of the things we're trying very hard to do is be a source of good, reliable, highly curated information that you, as a SADS healthcare provider or as a SADS family or whatever your connection is, where you can come here and learn and have a reliable source. And to that end, I will put in a plug on our website. If you are feeling generous to support this dissemination of knowledge, please go to the website and consider making a donation. We have volunteers, and we are still planning on getting together for in-person gatherings, so appreciate your support. So that's it for us today, and I look forward to coming back to you next month with another exciting topic and another opportunity for me to learn together with you. Thanks very much.